Good evening. My name is Roxanne Chabot from RBC Consultants. Welcome to our educational webinar. This evening, we're going to be talking about psychodermatological issues facing acne patients. Our moderator this evening is Dr. Charles Lind. Dr. Lind is Chief Medical Director at the Lind Institute for Dermatology and Linderm Research, as well as Associate Professor at University of Toronto, Department of Medicine. Our guest speaker this evening is Dr. Evan Reeder. Dr. Reeder is board-certified dermatologist and psychiatrist in the private practice in New York City, New York. We'd like to thank our supporters, Cypher, for making this educational event possible. Before we begin, if you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you would like to submit a question to our faculty, please use the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in your browser and will be emailed to you 1 to 2 days later. We would greatly appreciate it if you could fill it in and send it back to us. Within 1 to 2 days of the webinar, the recording of this program and a certificate of attendance would also be sent to you. Again, if you want to submit questions, please use the question chat pane on the right-hand side of your screen, and I wrote a note there so that you could see where you need to type in your questions. The opinions expressed in this presentations are that of the presenters. They do not necessarily reflect the opinions of Cypher Pharmaceuticals. So without further ado, I'd like to pass the floor virtually to Dr. Lind. Dr. Lind?
I know.
There we go. We can hear you. We can't see you.
And yeah, now there I am. Sorry, pardon me. So welcome everyone. This is a further webinar in our series. We've had quite a number of webinars surrounding acne. We've had ones about skin of color. We've had ones around hormonal issues in acne. And tonight we're going to talk about psychodermatological problems around acne. I think all of you recognize that acne is an extremely common skin problem. It's estimated that about 15% of a dermatologist practice surrounds acne, and essentially everybody in the world at some point gets acne. So an extremely positive thing. You know, the biggest, I think, advance around acne ever, and continues to be so, is the use of isotretinoin. It's made such a difference for all of our patients over the years. Actually, I just tell everybody I was there in 1979 and 1980 doing these trials around isotretinoin, and it was quite amazing to see how, in fact, this is a drug that got rid of people's anxiety, depression around this disease, and gave back their quality of life. So tonight we actually have a great expert that's going to talk a bit about the psychodermatology. I think it's a great sort of thing. But I want to start with a polling question. Maybe we can put up the polling question, Roxanne. So this is one of the things I think is the meat of the evening. Isotretinoin can cause depression in susceptible individuals, ? And I'd like to see what people in the audience would say. Yes, it can. No, it cannot. And see, those are fence sitters. Maybe it can. So if everybody can vote, please. I thought that's what the answer would probably be. We got to basically have pretty much a third and a third and a third. So hence the controversy that we're hopefully going to be able to address tonight and help all of us that prescribe this drug understand the issues surrounding this. We'll go, yes. So tonight we have Dr. Reeder. Dr. Reeder's from New York, and interestingly, he's one of 3 American physicians to have the dual board certified in dermatology and psychiatry. A graduate of NYU, both in psychiatry and dermatology. and he's written and edited 2 textbooks on aesthetics, published extensively in peer-reviewed dermatology. And something I didn't know, he does the dermatology show on Sirius XM radio. And I listen to that every morning when I come to the office and every night when I go home. And he's frequently asked these questions around psychodermatology. He's now gone basically into a private boutique medical and cosmetic practice, and he's spent 7 years as full-time faculty at NYU. So it's a great honor to have Dr. Reeder here tonight, and he's going to basically, hopefully, change those 1/3, 1/3, and 1/3 so that we understand this disease and its depression, and whether this does surround the isotretinoin and acne, or is it just the acne itself. Dr. Reeder, I pass the floor to you.
Okay, let's see. Thank you so much, Dr. Lynn, and thank you, Roxanne and RBC Consultants, for having me, and thank you, Cypher, for sponsoring this webinar. This is obviously a topic that's very near and dear to my heart as someone who's both a psychiatrist and a dermatologist. I always say, and sound like a broken record when I talk about it, that acne is the quintessential medical, cosmetic, and psychological disorder, and it hits all of us at some point in our lives, just like Dr. Lynn said. So I think this is really like the key example of a true psychodermatologic issue. I usually stay away from that word psychodermatology because I feel it makes you sound like a dermatologist who's crazy. But psychodermatology seems to be having a moment right now, and even like the beauty editors want to talk about it. So I'm really excited that something that's been a sort of a passion project of mine since I decided to do 2 residencies is actually coming into the foreground, and people are starting to give it its due. So with that being said, I'm going to try to take control over the mouse here and advance the slides, and we'll hopefully be able to impart some interesting information about isotretinoin and acne today. Let's see. Try again. There we go. Okay, so this is called what I call the isotretinoin and mental health controversies. So I'm just going to start with a quote from Marion Salzberger. Everyone probably knows there's probably no single disease which causes more psychic trauma, more maladjustment between parents and children, more general insecurity and feeling of inferiority, and greater sums of psychic suffering than does acne vulgaris. There's probably other conditions in the world of psychiatry that do that, but in terms of what we see at bread and butter dermatology, I totally agree with this sentiment. And I think that a lot of times we are not doing all that we can in dermatology to be able to address this. And we're amazing in dealing with the medical part, but especially in the United States, and I imagine the system is very similar in Canada, it's based on volume. So a lot of times people do not have the bandwidth to be able to fully address acne in the all-encompassing holistic way that we want to be able to, but it's a lofty goal that we're trying to be able to meet in the most efficient way possible. Okay, so I like to talk about Erik Erikson's stages of psychosocial development, just like a little piece of psychology. These little stages occur at challenging points in people's psychological development. And basically, he's a psychologist and basically said that at every stage in life, you have to make it through a struggle to be able to make it to the following stage. And acne is happening at these challenging points in our psychological development. Our teenage years, when people are extremely vulnerable to the impressions of others, when people don't feel comfortable necessarily in social situations, in a time when your identity is actually consolidating. People don't really even totally know who they are until they make it into their late or mid to the late 20s. And then in adulthood, we are really seeing an epidemic of adult acne, especially adult female acne. And I think that when acne hits us, it comes at a very unexpected moment. I have every week someone comes into my practice who's 30 and above, 40 and above, with new onset acne. I have never had this in my life, and now I'm having acne. So it's really linked to our social and occupational functioning, and it's really happening at an unfortunate time where people feel very embarrassed about it, and they said, you know, this really shouldn't be happening to me. Aren't I past this part in our life, in my life? So it's not lost on me that's happening at these times of different psychological challenges. So any way you slice the data, when you look at acne and patient-reported outcomes, and that seems to be one of the things that's at least really important in the US FDA in terms of getting medications through the committees and then approved, people want to know what patients say about their treatment. So acne is consistently associated with decreased quality of life, decreased satisfaction with appearance and self-esteem, decreased social engagement and academic performance, and even decreased employment when it's severe, and sometimes when not as severe as we may think when we look at it objectively. And when you're looking at acne and depression prevalence, general population, people have about 5 to 8.9% of depression. And I think that comes from US data. And I can't remember if that's US or global data. I think it's US data. And adolescents all have some acne, and 10 to 20% have moderate to severe acne. So you're going to be dealing with like a good percentage of our adolescent population that's going to be having depression as well. And I apologize, you may hear, I have a 7-month-old at home and she's crying a little bit in the background. So that's maybe the music you're hearing. And as acne severity increases, suicidal ideation reporting increases. As depression scores go down, acne severity goes down. So that's a little bit of background. And the psychological sequelae are actually a little bit more broad than one may think. We know, and I think colloquially and anecdotally, we all sort of talk about acne and the risks of depression and anxiety, and that's sort of understood. But I think that the association between acne and suicidal thoughts and behaviors is one that's perhaps a little bit more controversial, but one that if you dig into the literature, you will see it pretty consistently. But skin picking disorder can be very common in patients with acne. And even body dysmorphic disorder. There's been at least 3 publications in high quality journals that I know about that have shown an association, but not necessarily a causality between acne and body dysmorphic disorder, which I thought was a very interesting one. And I think body dysmorphic disorder, like the whole field of psychodermatology, is having a moment largely due to what we're seeing on social media and somewhat of the bastardization of this term, but the destigmatization of the term body dysmorphic disorder, and so people are more familiar with it in the social lexicon, and more people are talking about it. So I'm hoping that people who may be living with this disorder are seeing it a little bit more. But for me, it's always been early aggressive intervention is like the most important part of treating acne, and you sort of have to meet people where they are, because what may appear to be objectively mild in my eyes is often perceived as severe in the eyes and the experience of my patients. And everybody has different patient populations. And at this point in my career, I have a lot of the worried well in New York, and a lot of people who live in Manhattan and downtown whose appearance is really often key to not only their social functioning, but their occupational functioning. If you have people who are actors or models or people who are conducting business in high profile arenas, it's really important to them to have perfectly clear skin. And sometimes mild acne where there's a couple inflammatory bumps can be, you know, a dermatologic emergency. Okay, so what do we know about isotretinoin and mood? Okay, let's see if I can advance this. And I think this is where a lot of the controversy really comes into play. I'm going to talk about the backgrounds and origins of the associations or lack thereof between isotretinoin and mood disorders, what the current evidence shows, talk about my approach, and if we get to it later, we can touch on some frontier areas, and I don't think we'll be able to get to that today, but we'll see what we can do. And then we'll sort of wrap things up, and hopefully we'll have some more clarity, especially with respect to that first question that was asked about isotretinoin mood. So background and origins. So hypervitaminosis A was a syndrome that was first described in 1987, consisting of lethargy, depression, cyclothymia, sleep disruption, irritability, psychosis. Okay, remember tretinoin, isotretinoin, acetretin, all vitamin A derivatives, and after it was reported, there have been multiple case reports of people that were overdosing on vitamin A in various different forms. All those case reports resolve with cessation of vitamin A intake. And so if you look back to the original isotretinoin reports, the FDA sort of took a look at that in the United States, and they required Roche to label isotretinoin with the phrase Accutane may cause depression, psychosis, and rarely suicidal ideation, suicide attempts, and suicide. So there's potential mechanisms that were really addressed in the psychiatric literature, but not so much in the dermatologic literature. We've been really more interested in looking at the association between isotretinoin and psychiatric disorders from epidemiologic perspectives. But the psych literature showed that poisoning by and overdosing with vitamin A was reported to cause depression. And then preclinical and clinical results showed excess or deficiency of the retinoic acid retinoic acid, was associated with behavioral change, including depressions. And then when you look at animal models, they showed that exposure to retinoic acid can cause depressive behaviors. And there's actually data looking at specific regions of the brain that show increased expression of the retinoic acid inducible or induced gene in parts of the brains that are responsible for complex cognitive and intellectual functionings, especially in patients with bipolar disorder, major depression, and schizophrenia. And there's even interesting studies that are looking at brain imaging showing cerebral metabolism in the orbitofrontal cortex, again, a place that is important for executive functioning, gets reduced by 21% after 4 months on isotretinoin treatment, as compared to 2% in patients that were treated with antibiotics. So there's something going on there, right? And that was one of the reasons that the psychiatrists were so interested in looking at these psychiatric outcomes. And I think that isotretinoin, after they put this warning on it, there was a lot of media attention, and I think that would have gotten a much bigger splash today and may have spelled bigger trouble for isotretinoin had it happened in the era of social media. You know, what happened with Salik, and thinking about psoriasis data, where they had a couple cases of suicidal ideation and suicide attempts that really killed that drug, which is an amazing drug for psoriasis, but it's never going to have the prescribing patterns that perhaps it should, because of that one case series that came out in the American Academy Dermatology Journal. But there was 3 cases that I want people to sort of be aware about. There's a 2000 suicide of BJ Stupak, who was a 17-year-old son of a Michigan congressman, got a lot of media coverage. So he had this boy had been on Accutane, and then a year after he had gone off Accutane, he ended up committed suicide, and then the family sued Roche. They saying the Accutane changed his brain chemistry in some way, causing him to have depression, causing him to have suicidal ideation. Court ultimately ruled in favor of Roche, and they said the association was not well supported. A couple of years later, there was this is from, I can't remember what publication this is from, but Charles Bishop, a 15-year-old boy with no psychiatric history. Basically, I don't know how he got his hands on a stolen plane, but he was flying a stolen plane in Tampa, and he crashed into an office tower after being on Accutane for a couple months. I don't believe he was on an entire course, and I don't think he was actually on the medication at that time. It turns out after like the big splash happened in the media, when people did their due diligence, they found a note that he had written that it was basically sympathetic with Al Qaeda and Osama bin Laden, and they ended up dropping the suit against Roche for Accutane-induced psychosis because it looks like something else was part of the picture. But the media had sort of poisoned the well again. And then in 2012, there was a documentary on BBC 3 where they talked about isotretinoin and the experiences, at least of one boy, but maybe others. So it's talking about a man at this time named Jesse Jones, who was 24 years old, who had been on isotretinoin for 3 months and stopped after taking it because he said he was having mood swings. And then that was in 2009, and he said he continued to have depression even after the medication was out of his system. And then a couple years later, ended up committing suicide by jumping off a cliff, and wrote a note, and I'll read it because I have it written down. He said, Roaccutane, which is the version of Accutane that's available in the UK market, Roaccutane seems to have changed the way my mind and body works. So again, lots of media exposure for this, and not in the way that's so positive. So in the time that these things were happening and the media exposure and these case reports were happening out, the United States FDA made an alert to monitor patients on isotretinoin for suicidal ideation. And in 2005, the iPledge program, which I won't get into because it's a nightmare and you don't have to deal with it in Canada, was established by the FDA in the United States. So in thinking about like better studies and larger studies, there was a study that came out in 2010, and this was like, at that time, this was the first and until recently, the only large epidemiological study of isotretinoin and suicidal behavior. And it basically said that the risk of suicide attempt was increased under isotretinoin, but also that the start of this increase was detectable in terms of suicidal ideation, was detectable before treatment initiation of isotretinoin. But you really wouldn't know that by looking at the title of the paper, and you have to sort of read it very clearly. So this pre-isotretinoin risk was attributed to a severe acne itself. This is a big study. This is a retrospective cohort study coming from Sweden, looking at more than 5,000 patients that were treated from isotretinoin in the 1980s, from 1980 to 1989. And so that was one of the first big reports looking at epidemiologic evidence of isotretinoin and suicidality. So more recently, we've had some major studies come into the evidence in some of the major journals, especially coming out of JAMA and the American and the JAD. So there was a meta-analysis that came out this is from 2016, and they showed, looking at all the sort of controlled data and uncontrolled prospective data of at least 15 patients with acne. 31 studies met criteria. This was through 2016. And at this time, they said, in terms of psychopathology that came from people being on isotretinoin, it was sort of mixed, but was mostly positive. They said isotretinoin helped with quality of life, helped with reducing depression scores, reducing anxiety scores, but some of the data was negative in that they didn't think that isotretinoin helped and then actually may have hurt, and some of it was equivocal, all right? But in general, they said isotretinoin for acne does not appear to be associated with an increased risk for depression. And moreover, the treatment of acne with isotretinoin seems to ameliorate the symptoms of depression. And this was in the American Academy of Dermatology in 2016, 2017. Okay, you don't need that graph because I just talked about it. Okay. And then there's a much bigger study that came out in 2019. This is also, I think this is in JAMA Derm. This is a big retrospective study of the frequency and type of psychiatric adverse events on patients who are on isotretinoin. I think I have a graph here. And so this is basically looking at the things that we really care about, right? More than 17,000 patients were tracked in this database, and they found, here's their data here showing the suicide reports to the FDA and the rates of completed suicide in patients enrolled in the iPledge system. So these were reported, and if you look all the way to the bottom, I think this is the meat of what you need to take home from this. Completed suicides for 100,000 patients who are enrolled in the iPledge program, meaning that these are American patients that were taking isotretinoin and they were in the iPledge program at the time. 8.4 in 2009, and then 2010 it was 5.6, and then you have the general population, their rates of suicide, which were substantially higher, 11.8 in 2009, and in 2010, 12.1. So it seems to have a protective effect. So, and the meat of this, the story here was the rates of suicide among patients on isotretinoin may be lower than that, the general population. Again, this is looking at more than 17,000 people. It's a major database study. And then this is basically showing some other psychiatric outcomes. There are many other psychiatric adverse events that they think may be associated with the being on isotretinoin, but a lot of this stuff has not been yet reproduced. But I think the take-home point is about the suicidal ideation, which seems to be protective. Okay. Another study, then this actually came from NYU a couple of years ago, looking at more than 70,000 people in this IBM market scan database. This is looking at insurance claims that were happening for commercial insurers in the United States. And so this was looking at patients who were on isotretinoin versus oral antibiotics. And these were people looking at psychiatric disorders and suicidal ideation and behaviors. This is going to be really hard to read. Okay, so basically I'll just talk you through the main points here. So when controlling for age and sex and number of days enrolled, individuals in the general population has significantly higher odds of just demonstrating suicidal ideation behavior than acne patients that have been prescribed that have been prescribed isotretinoin. But interestingly enough, the general population and the acne patients on antibiotics were less likely to have a pre-existing psychiatric diagnosis, and suicidal ideation and behaviors were more likely in the general population. So if you were on the, let me go back. So I think one of the things that people worry about with isotretinoin and thinking about depression is, are dermatologists aware of this association, or were they concerned about the association? So were they withholding isotretinoin from patients who they thought were somewhat mood dysregulated to begin with? And the data from this is suggesting no. It's suggesting that the patient population who received isotretinoin was perhaps more psychologically ill, but still their psychiatric outcomes were much more positive while being on isotretinoin than the general population who had been on antibiotics and who had not been as psychologically ill. I hope that makes sense. Okay, and this graph basically shows, I know that the writing is probably small, that if you look at the year before and the year after people were on isotretinoin, their scores for depression and suicidal ideation were actually the best when they were actually taking the medication, better than they were before and better than they were after. Begs the question of why did they sort of revert down after they were on isotretinoin? Why would the suicidal ideation get higher? And there's theories about that, but I don't know for sure. Okay, similar data coming from nationwide study that comes from France. This is a cohort and nested case control study of patients on isotretinoin and suicide attempts. And this is basically another way of showing that the occurrence of suicide attempts and under isotretinoin was much lower than the general population. And the graph above shows 1 year prior to, let me see if I can read this here. This is like the year that patients were on isotretinoin, so they were doing much better in terms of suicidal ideation than they were doing in the 5 years before and the 5 years after being on Accutane. And there was, importantly, one other thing that people talk about is there a triggering effect, especially in the beginning of people being on this medication, just it sort of revved them up, and they didn't find that there was any triggering effect after 2 to 3 months being on medication. More take-home points from this: suicidal events were rare, occurred different times during the treatment, and was not associated with higher dosages or cumulative dosages. In fact, the higher cumulative dose you got, you have the lower risk of suicidal ideation, of suicidal attempts, excuse me. And then if looking back at the patient populations, psych history and anxiety specifically were risk factors for suicide attempts. I'm not sure if there's much to take home from that, but that's where their data sort of shook out, and I don't think that's been reproduced anywhere else. Similar study came from Taiwan just last year, almost 30,000 patients with 16-year follow-up, also found no increased risk of psychiatric disorders in patients on isotretinoin. That's a little bit more of a broad statement because we did see that there was increased risk of some psychiatric disorders, but that hasn't been consistent looking at isotretinoin. Increased daily dosage, longer duration also did not increase the risk. And then finally, I want to talk about this study here that sort of brings back the question mark. This is a study that was just published like within the last couple months. I believe this came from Germany. 75,000 acne patients on isotretinoin, and then another group of patients, there were more than 75,000 patients on oral antibiotics, and they were compared after their treatment, looking at the risk of 9 different psychiatric outcomes. So in the patients with isotretinoin, they had lower depression scores, lowered PTSD, anxiety, bipolar disorder exacerbations, lower exacerbations of schizophrenia or onset of schizophrenia, and lower incidence of adjustment disorders. But they had comparable risks of major depressive disorder, and suicide attempt, and then higher risk of suicidal ideation. So this was sort of like a real bummer for me to read. And it's there are some questions about the study, but I think it was a good study. It is a single patient population, but it's a large database study. And I think I was very optimistic they were sort of out of the woods in this question about the association between isotretinoin and depression and isotretinoin and suicidality. And this sort of, I think, takes us a step back to a certain extent. One thing I do want to mention, and that's really where we are for the large epidemiologic studies. One thing I do want to mention is one thing that I ask people about all the time when I'm initiating someone on isotretinoin is about prodromal symptoms. I don't think this study has been replicated, but this is one that came out a couple of years ago. It was a really small study looking at isotretinoin associated affective disorders. And what they found that there was an association with preceding prodromal symptoms: headaches, sleep disorders, fatigue, weakness, drowsiness. People who had end up having affective disorders after initiation of isotretinoin tended to have these symptoms. Headache was associated with depression in isotretinoin patients, and more recently they found that isotretinoin had been associated with insomnia. So insomnia and headache are two things that I'm always asking people about, and I don't think that's standardly done, but I think insomnia is a particularly interesting one because insomnia is a really uncommon symptom for our patient population who tends to be on Accutane to have. Teenagers tend to be people who are, if anything, hypersomnolent, right? And so I think the presence of insomnia would be something that may give me pause. I don't think I would withhold the medication from someone, but I would say this may be someone who is at risk of going into a mood disorder after being on isotretinoin or while they're on isotretinoin. So given that, and given all the epidemiologic studies, in 2014, the Medicines and Healthcare Products Regulatory Agency, they released a statement that said acne is associated with psychiatric disorders, not isotretinoin, but acne, but there was insufficient evidence to establish causality and can't rule out an association between isotretinoin and psychiatric disorders. But I think that what I want you to see from this data is that most of the time, and in fact, the vast majority of the time, especially when you're looking at these major database studies, that association that had been purported for many years between isotretinoin and suicidality, suicidal behavior, suicide attempt has not manifested. And recently, our United States FDA panel recommended modifications to the iPledge system, but nothing with respect to mental health outcomes. And again, I'm not going to belabor what happens in iPledge, but they do ask when you enroll people about mental health outcomes. And I think a lot of it has to do with like the inherently litigious environment that the United States is. And I don't know if these are standard questions to be asked in Canadian populations, but most every dermatologist in the United States is, for better or for worse, using this iPledge system as another layer of screening in thinking about their Accutane patients. So, and that's essentially what I do. I use the iPledge system to my advantage. I think it is an opportunity for screening, and it's an opportunity. It may not be something that I would have needed in my own practice, but sort of to the American dermatologist, it brings on top of mind these associations, whether they're real or they're not. And so we're monitoring patients because once in a while you will see an outlier where someone says they went on isotretinoin and they had some sort of adverse reaction. And a lot of times those are psychiatric, even though that has not been manifested in the literature, especially in the major epidemiologic literature. I do use the PHQ-2 to screen. It's a really good screener for depression. It's very efficient. And I ask questions about prodromal symptoms, headaches, sleep, especially insomnia. And again, I don't withhold the medication to people who have insomnia, but it does give me pause and it does get me to think about whether or not this person could be someone who's more vulnerable to the effects of isotretinoin. And again, I don't I don't think so. And then that was a small study that I was talking about. It really hasn't been replicated yet, but it's something in the back of my mind. And I always say that patient report, as I sort of talked about before, patient reported outcomes, I think about them often more strongly than I do with my own objective findings. And I have a low threshold to put people on isotretinoin, and even I don't know what you call low dose isotretinoin. In Canada, I call it Hollywood dosing or European dosing. I have a lot of patients who are on, 10 milligrams 5 times a week or 3 times a week, because it can be really helpful to keep even that mild acne at bay for people who can't tolerate to even have a couple of spots on their face. And then I also use mental health colleagues as my resources. I'm very lucky in that I have a lot of colleagues in psychology and psychiatry, and I have them all on my phone, and I would encourage you to do the same thing if you have colleagues, because we have so many conditions in dermatology that do have psychiatric overlay that it would be worth having people in your Rolodex easily accessible that you can refer patients to, because these situations do come up, and especially if you're dealing with people who are psychologically vulnerable, cosmetically sensitive, it's not an uncommon thing to make a referral. And also to ask for your own peace of mind for another consultation or to ask questions. This is the questions from the patient health questionnaire tool. This basically says, do you have little interest or pleasure in doing things over the last 2 weeks? And have you been feeling down, depressed, or hopeless? If you score 3 or higher, it has 97% sensitivity and 67% specificity for screening for depression. So I hope this is somewhat helpful, and I think that the take-home points that I want people to leave with is acne is consistently associated with lower quality of life and a multitude of adverse mental health outcomes. The psychiatric literature did suggest a causal link between isotretinoin and depression, and although the early dermatologic data did support that, it's really limited to case reports. Even though those case reports did come from all over the world, they were still case reports. And then when you look at the epidemiologic studies of hundreds of thousands of patients, or tens of thousands of patients, all of them except for this most recent one refute this. This was a stronger talk 3 months ago before that paper came out, and I think that still should give us pause, but I think that we'll continue to get more data to show that that association between suicidality and acne is not something that is going to be replicated. Suicidality and isotretinoin is not something that's going to be replicated. But I still do ask the screening questions, because I do think that the patient population with acne is very vulnerable, and I think the patient population with acne who you having the conversation about isotretinoin with is particularly vulnerable as well, because they've, at least on their patient-reported outcomes or on your objective data, you have determined that they are severe enough to be, moderately severe enough to be on a medication like isotretinoin, which I do think is a life-changing medication for people. But I would encourage you to sort of stay tuned to what's happening in the literature, and even stay tuned to what's happening in the American FDA, because I think that we're very annoying and very slow in the way that they change things, but hopefully they will be responsive to the complaints from American doctors and change the way that the prescribing patterns, or the whatever they're doing to sort of put sand in the gears of the prescribing patterns of the dermatologists. Hopefully that gets changed here. But in general, I do think, as Dr. Lin said, this is a life-changing medication for people, and it's one that I prescribe on a daily basis. And I don't want people to be scared about the mental health outcomes that can be coming from this, especially with respect to depression and suicidality, because the data does not support that. Okay, and that's what I have for you today.
Thank you very much, Dr. Reeder. It's a great overview of what we know now about the association of isotretinoin, or the non-association with isotretinoin. So maybe we'll go on to the next part here. While we're doing this, we would like you to put in your questions in the chat. There's already some questions that have come in on the chat, but we'd hopefully be able to answer them over the next 15 or 20 minutes for you. And while we're waiting for that, all you have to do is go to the chat button. I think everybody knows that. Put your question in there, we'll read it and try to answer it for you. So I want to sort of, while everybody's putting in some of the questions, just to remind people and ask the first question to our great speaker, Dr. Reeder. So just to remind you that, you know, for isotretinoin, you need to have a high-fat meal. And you have to basically have a kind of a quotation marks big boy breakfast that you're supposed to have with the isotretinoin to get a good, usually it's, again, one that's about 1,000 calories. It's eggs, bacon, lots of butter. And basically, you know, this is something that isn't very realistic for most people on the kind of Accutane itself, because these are adolescents, young adults. They're not having this type of breakfast. They may be not having any breakfast at all, or maybe just a smoothie or something else. And we know that the newer drug, Epirus, what newer, it's been out for a number of years, but the newer generation, if you would, isotretinoin doesn't require this. Just to let you know that there are things, because some people don't take dairy. These are other alternatives if you are prescribing Accutane that you could get use. Avocado, just an egg by itself, a little bit of meat, or even peanut butter are also alternatives to dairy products such as yogurt, milk, etc. And this is, again, I think everybody's seen this and everybody understands this, that with the drug Epirus, there's bioequivalence. So in a fasted state, the absorption of Epirus is approximately 83% higher than Accutane. So basically in my practice, because I know the population, they're really not interested in having fat. They basically prefer this this product. Now, the question I have, just to get things started for Dr. Reeder, you know, in this population, often a young female, 17, 18, you bring up the word fat. Oh yeah, you got to take this drug with fat. That I don't think is something that they want to hear, or will they do. And I think personally that the use of Epirus is something that decreases their anxiety around even taking this drug. So I'd be interested in your take on this.
I couldn't agree more. And I think I learned this very early on in my practice. And I remember one of the first people I put on isotretinoin was a young woman who was in her early 20s. And so you have to take it with a fatty meal. And I said, avocado's okay. And like, that was sort of like a happy medium. But she was like, you know, she'd been on the medication for 6 months or so, and she was completely clear. And she's like, if I will never eat an avocado again for the rest of my life because I'm so disgusted by this. And it wasn't even that she gained weight, but it was just like, you know, whatever food you choose, and you're going to be like eating it over and over again. But if you have to choose a high fat food, it doesn't matter who you are. I think if you are a patient with acne, you're coming in to see the dermatologist and you're willing to take isotretinoin, you've already pre-selected yourself as someone who is really invested in what they look like, right? And there's people who probably should be on isotretinoin who never make it into a dermatologist's office for a lot of different reasons. Some of them it's just because their skin is not as much a priority to them as it would be to one of us. But I think it's like it's a huge area where I think that the medications on the market right now that do require a high fat meal are failing the patient population, because like I said, for some people it's a non-starter. They'll say, well, I'll try my best on taking isotretinoin, but I'm not going to be changing my dietary habits, and there's no way I'm going to be eating like a bunch of bacon with my meals in the morning and putting on 10, 15 pounds to get my acne cleared. So it's filling a huge need. Yeah, that's what I would say.
Good. Glad you agree with me. Thank you. So I think what we'll do next is we'll do the polling question. The polling question is the same as what we had before, and see where we're at. And then we're going to have what we've come in on the chat and answer them. So please, if you can answer this, and we'll see if we come up with a third, and a third again. Yes, it can. No, it doesn't. Maybe. Right, can we show the results? Yeah, okay, so we've actually changed it here a little bit. So I guess you know that, as you were saying, Dr. Reeder, the last paper there maybe is one. As you also said, maybe this won't be replicated, but I think there's just pointing out that the point that you had about being vigilant, I think in general, we feel that really doesn't. We know that it certainly improves quality of life in our patients, and for the most part, it doesn't. But I think I explain it to my patients that there is controversy around this, and I give them my spin on it. That I think that this is going to improve your mood, decrease your anxiety, decrease your depression overall. But I think you're vigilant. If you have a patient that's already had a suicidal ideation, suicidal attempt, then that's where you're going to get to your colleague, your psychiatrist, and talk to them about this. And just to kind of, these are the conclusions, and that you know, this is common in this age group. So we know that the peer pressure and having acne increases your suicidal ideation in this age group. The literature suggests a causal link with it early on. The early data supports that, but really most of the epidemiological studies and the database studies actually refute it, other than that one paper. So again, remains to this day the best treatment for acne and has the best safety in the efficacy program. I mean, like you, Dr. Reeder, I prescribe this many times every day. But I ask about mood. I ask about them before they go on it. And I basically, each time that I see them subsequently, I again ask about mood, and I document that in my chart because I want patients to do well, and maybe their mood is different, but it may be unrelated to completely to the drug. So I think we'll have the questions, Roxanne. I think you may hopefully have some from our listeners.
Absolutely. And remember, please use the question chat pane on the right-hand side of your screen. Any additional questions that you think of after the webinar, you can submit to info@RBC Consultants. We'd like to thank again our supporter, Cypher, for making this educational event possible. So let's go to the questions. Should I withhold isotretinoin from patients who are currently depressed?
Let our esteemed psychiatrist and dermatologist answer that one first. You're on mute, I think.
Yep, you're on mute, Dr. Reeder. Just click on that little red microphone there, if you can see it.
I'm sorry, it was hidden behind the screen. Okay. The question is, would I withhold isotretinoin from someone who's depressed, correct?
Yes.
Okay. So I think that in my clinical practice, I would not do that. And the evidence shows that the association between acne and depression is severe, and the association between isotretinoin and depression is either non-existent or has been spuriously reported. So the data shows that if you put someone with depression on isotretinoin, their depression scores are going to improve as their skin improves. So no, I would not do that. Yeah. If it was severe depression,
how cautious? How cautious would you be? In other words, if a person says, you know, I've been to 3 other dermatologists, I have this bad acne, I'm coming to you, Dr. Reeder. I really want to have the isotretinoin. I want to get better, want my appearance to be better, and I think my depression is really because of my acne. Are you?
Yeah, so I would, and I think that this threads the line, because I think that when you're dealing with someone who you are concerned that may have severe depression, then it's okay to phone a friend, and it's okay to say, you know what, I think that you're going to be a great candidate for isotretinoin, but I don't necessarily feel like we're getting the full story here. Why did you see 3 different dermatologists? Nobody wanted to do it. Are they withholding something that you should be getting, or are they just not comfortable because you haven't had a full psychiatric evaluation? Because depression, I think of, it's like when people say eczema. There's like a million different ways to get eczema. It's like a wastebasket term. And depression is a wastebasket term in a lot of different ways too. And people will say depression, but it means a lot of different things, and there's a lot of nuance to that. If someone has severe depression and they're like not eating and they're not enjoying life, or they're suicidal, those are questions that I don't think you're necessarily expected to ask as a dermatologist, but you should know when, like, you should get like the sixth sense after you ask the questions about if someone's not enjoying things, if someone's really severely depressed over the past couple of weeks, that maybe it's time to get an evaluation from someone else who can actually assess this and do what's called a risk assessment, which is basically saying, I think that this doesn't predict behavior, but what a psychiatrist or psychologist or mental health social worker will do will say, given the patient's risk factors and their history of whatever psychiatric outcomes or suicide, then I think that they're a low risk, medium risk, or high risk to be on this medication or to have a decompensation. So I think that it's okay to phone a friend if you are in a position where you feel a little uncomfortable. For me, I probably would be more comfortable prescribing and asking us some of these psychiatric questions just because I did several more years of training, but I don't think that should be necessarily in the purview of the general medical dermatologist.
I'd agree completely with you in terms of, if the person is, I'm feeling a little bit depressed because I only got 80 instead of 90 on my last exam or something, but they're not, they're sleeping well, they don't have headaches, they're not on any medication, they have no suicidal ideation. I usually would just basically, even without the psychiatrist helping me, I would go ahead and give them the drug. I basically tell them that, and if they're okay with it, and I basically get them to sign my chart, actually, say that we've discussed this and that there's a controversy around this area, and I'm being vigilant about it and with them. So again, everybody has to practice within their comfort level, but I see so many patients that really, I think, need the drug, and some of my colleagues are not giving it because they feel uncomfortable giving it. Next question, Roxanne.
How do you counsel, same trend of thought, how do you generally counsel patients about isotretinoin and mental health, depression, suicidality with the findings from these new epidemiological studies?
Yeah, so I'll take this one first, and let Dr. Reeder, you go ahead.
No, go ahead, it's fine.
Okay, well, the way I was part of it, I say, you can get pregnant and then all the side effects and everything else. And then I come down and I said, there's one other thing that we should discuss. The most important thing for you, say a woman, is not to get pregnant, but I need to discuss that there's some controversy around depression. This has gone on for a number of years. Most of the studies, epidemiological studies, actually refute it and don't believe it's a real thing. However, in the population that you're in, often the kind of late teens, early 20s, people are somewhat depressed, which has nothing to do with the drug, nothing maybe necessarily to do with the acne. And you should basically, if you feel down, your mood changes and everything else, then please stop the drug. Please let somebody else. And I often tell this to the parent, if the parent's with them, to watch them. And that's, again, what you would say your last word on the conclusions there, Dr. Reeder. Be vigilant. Watch the patients. I think is important.
Yeah, no, I totally agree with that. And I think that it's still possible for people to report some sort of psychiatric outcome that happens in the course of isotretinoin, and I give them the risk the same way. And then, even if it wouldn't be consistent with what we see in these epidemiologic studies, I tell people that, there are potential like hypersensitivity reactions, or where your immune system is just not doing well, or your body's not reacting to isotretinoin the way that we would want it to. So I just have people stop it and have them come back into the office and we discuss. And I've only seen that happen a couple of times, and I honestly, it wasn't really sure what to make of it. And I hate to use the term like psychosomatic, but a lot of things, the times that I've seen it happen, I was wondering what else was going on in this person's life. And there was often something else that was happening socially, with parental figures, with the relationships with others, that was a stressful event. And I was wondering if there was a displacement. I always like to treat things as if they're medical until proven otherwise, but it's something that I'm always thinking about when these adverse reactions that are atypical happen.
Also, part of my discussion is to flip it around and tell all the positive things, that this is going to clear your acne. It's going to allow us to decrease the scarring and changes on your face and give you your life back. And it actually increases their mood, and instead of decreasing it, makes them less anxious, makes them want to go to school, etc. And so I'm always pushing the positive side, but I explained that there is a controversy. Roxanne?
So again, in the same trend of thought, how do you fight isotretinoin-related misinformation online with the patients?
Well, I think Dr. Reeder explained before, there's a lot of misinformation on social media, and it continues. It only continues to get worse, and it's hard for kind of the uninitiated to understand what is real and what is not real. I usually tell people to disregard what they're seeing online because it probably is misinformation. This is an age of misinformation rather than an age of information. Dr. Reeder, what's your take on that?
Yeah, I think that's a hard topic. I use social media, but not as much as I could, or perhaps I should. And in the beginning, I was talking about isotretinoin a little bit, and I made a post that I thought was very sensitive about, like, I was saying, your dermatologist there's no association between isotretinoin and suicide or depression, at least not at that time there wasn't. There's a lot of misinformation out there, yet, if you're having such symptoms, your dermatologist is going to be asking you these questions. So don't worry, we're going to take care of you in like a very holistic way. And I got a barrage of like hate mail from these random people, and some of them were like veiled threats at my life, and it was actually kind of scary. There's a very vocal small sub community, and I don't know how they found each other, that are very anti-Accutane out there. So I think I do my Accutane information in the office with people who are coming to see me, and that actually made me stop fighting misinformation online, because I was at the point where I sort of felt threatened. It happened to a couple other dermatologists as well. So I think it's a major issue right now, not only misinformation, but like the vehemence of which some people, sort of like that short narrative I told you about one of the kids who unfortunately committed suicide. I think people think that there is a small community of people who think that this is a medication that have scarred them forever. And I don't know how to understand these patients, but I try not to engage with them online.
Body dysmorphia that occurs. Luckily, I think we have a little bit less of a problem in Canada than you have in the United States, but certainly, I guess there's probably some. Roxanne, our next question. Is there others?
Yes, there sure are. Does correcting, so actually, let's go to a question about isotretinoin. Can we take, and actually this is from our good friend, Dr. Loretta Fiorello, is there a problem taking isotretinoin with supper? Because typically supper contains fat.
Yes, so you could take it with supper. That's not a problem, because it does have fat, and you can take. And by the way, you can take the Epuris with fat if you wish, take it with supper, etc. It's just that that formulation is much more convenient for a lot of the population that doesn't want to take a lot of fat. Some of the suppers may not have very much fat. They're having a couple of carrot sticks and a bit of celery, even for dinner. But particularly I find young adults that get up in the morning, they're often not having a breakfast, not even having oatmeal or cereal or anything else. They're having maybe some orange juice and getting off to school. Similarly, with a lot of executives, similarly, they're taking a coffee on the subway or on their way to work and often not having a breakfast. So having the purest form just makes it so much easier for that population.
Yeah, and there's intermittent fasting, which is a huge thing where people stop eating 6 p.m. and then start eating again at 12. So the purist has a role for sure.
Yep.
And maybe one last question, does correcting the insomnia help prevent sequelae? If so, what do you use?
Dr. Reader?
That's a great question. Yeah, I don't know. I don't know. But when someone comes in with insomnia, depends. There's a lot of medications on the market. A lot of them are habit developing. If the person it depends on the flavor of insomnia. Sometimes I'll give a little touch of hydroxyzine, even like 10, 12, 15 milligrams of hydroxyzine. I will give mirtazapine if there is a component of depression or there's some problem with appetite as well, because sometimes people can gain weight on that medication, but 7.5 milligrams of mirtazapine is excellent for helping people with sedating properties. Melatonin can be helpful as well. I try to stay away from the sedative hypnotics and benzodiazepines, except for in a rare occasion when someone's in a really bad place with super high anxiety and they can't calm down, or they're super depressed, and we'll use the sedative hypnotics as sort of a bridge to get them through that crucial period. And because I don't want to develop these, I don't want them to use these medications as a crutch and develop bad habits because of them. But those are the medications that I will think of. Those are like my first line medications that I go to.
So, Roxanne, I think that's our time is up. Again,
Absolutely. Yeah, unfortunately, our time is up because I think we could discuss about this topic that's really not discussed a whole lot in our dermatological community. So thank you so much, Dr. Reader and Dr. Lynn, for giving us a platform to discuss this, and also Cypher and Apuris for giving us the platform to discuss this topic that's really compelling for acne patients everywhere. And I would like to thank you all for joining us this evening. Good night, everybody.
All right. Thanks, Dr. Reader. Thanks again. Bye-bye.